name is Kayla Del Biondo. I want to just welcome everybody on behalf of the library to tonight's program on telehealth with Dr. Larry Leibowitz and Michael Turpin. I'm going to give a brief introduction of their bios, which are impressive, so give me a minute to get through it. But we have Dr. Larry Leibowitz here tonight. He's board certified in family medicine. He's been in practice since 1999. With the launch of his concierge practice, Matrix Personalized Medicine in 2017, he began offering highly individualized care by addressing the unique needs and preferences of each of his patients. He has been recognized as a 2017, 2018, 2019, and 2020 Castle Colony Top Doc in Fairfield County, and he serves as the Director of Health for the town of Reading. We also have Michael Turpin with us tonight as a speaker. He is Executive Vice President of USI Insurance Services, and he brings over 35 years of experience in benefits and business insurance brokerage and consulting with him. Mike started his career with the brokerage firm Marsh & McLennan and served in various management and national roles in LA, Newport Beach, San Francisco, London, and New York. In 2008, Mike came to USI as a corporate EVP responsible for the US benefits strategy, operating structure, people, and processes. And he's a published author of 3 novels, contributing columnist for national industry and healthcare blogs and periodicals. He's a frequent speaker to employer and investor groups on issues relating to healthcare, market reform, employee benefits, and business insurance issues. And I'm hoping tonight we can just have a discussion about if telehealth is here to stay and kind of the future of telemedicine. I think Mike and Larry both bring awesome perspectives on this topic. They're going to give a little introduction about where they see this going, and then we're going to open it up to our audience for questions. So I'll turn it over to you both. Thank you for being here tonight.
Thanks, Kayla. Hi, everyone. Thank you all for joining the meeting, and thank you, Kayla, and also Bethany Zaro for inviting me to participate. It's an interesting and evolving topic, and I hope you all find the session informative. But before I get started, I would put a plug in for Mike's other book, 53 is the New 38, which is really amusing and a quick, fun read. So I encourage everybody to check that out. It's just a treatise on life, and I really enjoyed it. Anyway, as Kayla mentioned, my practice is membership-based, sometimes referred to as a concierge medicine practice, which means that my patients have enhanced access to me and my staff in real time, either in the office or remotely, and that my patient panel is much smaller by design, which enables me to be more available and to spend more time with my patients in a more personalized way. I'm also able to get to know my patients much more thoroughly than I ever had in a more traditional practice setting, which is where I spent most of my career prior to 2017. And this new and improved practice model works really well. My patients find it really satisfying, and I certainly do as well. One of the really nice things about practices like mine is that patients have access to me even outside of the office. I often discuss medical issues with patients remotely, simply because it's their preference and it's more convenient for them. However, pre-COVID, most of my interactions were still here in the office, but all that changed earlier in the year when the pandemic struck. Understandably, people became more wary of leaving the home and going to doctor's offices, and yet all of the traditional medical issues didn't simply disappear. We still had to address them. So as a result, telehealth became a mainstay for me, and I imagine for many other doctors in similar practices, and it's really worked well. When properly delivered, telemedicine can serve as a very effective and appropriate means of managing both acute and chronic medical issues. One of the cardinal rules, in fact, that all doctors are taught in medical school is that 90% of making a proper diagnosis is based on listening and asking the right questions, taking a good history from our patients. And this is essentially what telehealth is all about. We may not necessarily always be in the room with our patients, but telemedicine can often effectively bridge that gap. In employing these virtual technologies so that we can see and hear our patients in real time, doctors can synthesize the information that we gather in order to come up with an appropriate course of action that's suitable to the needs of an individual patient. Of course, there will always be times in which patients need to be seen in the office in order to do an adequate assessment. That critical aspect of medicine will never go away, nor should it, nor do we want it to. But as it turns out, telehealth works quite well in many, if not most cases. Although I've begun to slowly reopen my practice over the last several weeks as the pandemic has slowed down, at least in our region, patients have grown accustomed to the telemedicine consultations over the course of time, over the last few months, and in many cases, they continue to prefer it. With proper information and technologies in place, telemedicine can be practiced both safely and effectively. When the pandemic did strike, the government loosened some of the restrictions with respect to telemedicine visits that were previously in place. So ordinarily, physicians had to use particular approved platforms that enable doctors and patients to communicate securely. However, because accessing those platforms can sometimes be costly or logistically challenging, especially for patients, practices have been granted at least some form of temporary permission by the US Department of Health and Human Services to use more familiar platforms such as Zoom or Skype or FaceTime in order to conduct these telehealth visits for patients during the pandemic. It's likely at some point that these regulations will tighten up again, such that the practice of telehealth will be limited to dedicated platforms. There will always be concerns with respect to protection of personal information and data breaches in this increasingly technological world that we live in, and healthcare is certainly not immune to that. So some of these platforms are quite appropriate for that. But for the time being, in the interest of keeping our patients and communities safe and healthy, regulations have been relaxed, and some insurers are even required to reimburse physicians for telemedicine visits, although what I'm hearing is that those reimbursements can be somewhat modest. So did I miss in-person interactions with our patients? Absolutely. And I'm glad, at least for the time being, I'm once again seeing patients in my office. But we've all experienced what it's like to take time out of our day to drive to a doctor's office, to sit in a waiting room, often for what seems like an eternity, in order to be seen by a doctor within a relatively compressed time slot. And we all know from experience that, let's be honest, doctors tend to run late, which leads to an even more protracted healthcare experience for the patient. For working people especially, taking time out of the day to visit a doctor can have significant impacts on their workflow and livelihood. For parents, it often means hiring a babysitter to watch over their kids while they're out of the house. For people with disabilities or who have limited access to transportation or who may need assistance leaving the house or who are otherwise homebound, this telehealth model can really provide a lot of benefit, and the traditional model can be really onerous for them. Yet this isn't often the fault of physicians, really. I mean, in our current model, practices can only cover their expenses if they see as many patients as possible in the office over the course of a workday so that they can bill insurance and collect copays. And because of ever-rising overhead and administrative costs, docs need to see a lot of patients over the course of a day, which unfortunately can leave major gaps in terms of quality of care. In short, medicine has become more of a volume-based industry over time. And as one of my colleagues once said, candidly, because she's forced to see 30 patients per day, she's concerned that she may be making 30 mistakes per day, just because the time isn't there to devote to each patient interaction. And the process isn't just onerous, it isn't just inefficient, but it's also less humane, in my opinion, for all the reasons that I mentioned. So these newer practice models and approaches are successfully making this, what I think is a defunct system, a thing of the past. And another nice quality of telehealth is its ability to enable practitioners to deliver more seamless, comprehensive care, whereas traditionally patients are entitled to one physical per year in which all relevant health maintenance protocols and prevention measures are expected to be discussed or delivered. With the emergence of telemedicine, continuity is much more of a mainstay. For patients with chronic conditions, for instance, it's much easier and more convenient for the patient to check in virtually on a regular basis without all of the trappings of the traditional model, as I had delineated earlier. Another important aspect of telemedicine is that it enables doctors to connect with our patients on a much more regular basis so that we can truly practice good, consistent preventative medicine. And with the advent of telemedicine, we can do a better job of keeping our people healthy, our patients healthy. And as increasing numbers of people live longer with chronic medical conditions, this level of seamless care and access that telemedicine can provide will become increasingly critical over the course of time. I'm convinced of it. And many people in the field, I'm sure Mike will agree, are convinced of it. Our current system is much more rooted in disease management right now than it is in preventative health. So doctors are not compensated nearly as well, frankly, for preventative medicine as they are for visits for illnesses or disease management, during which tests may be ordered or prescriptions may be ordered or procedures may be performed, which is why so many medical students want to be dermatologists these days. Here's an insider's perspective. Doctors are compensated by insurers based on the complexity of a given patient interaction, which at first blush makes sense, right? Except that the measures by which a level of complexity is determined are rather skewed. So for instance, a provider is compensated more generously for, say, a 15-minute visit if a prescription is provided, for instance, Lipitor for cholesterol lowering, than if that same 15 minutes were spent providing lifestyle and nutritional counseling in order to get those cholesterol levels down, even though the guidelines universally recommend lifestyle modification as the primary means by which high cholesterol should be managed. So the motivation is to prescribe, rather than practice true preventative medicine. You may not know this either, but Medicare doesn't even provide an annual physical exam. Medicare's version of an annual wellness visit is really just a brief question and answer session to ensure that patients are accessing bare bones screening protocols. But if a doctor performs a full physical examination in the course of a Medicare wellness visit, they are doing it for free. A physical exam is not covered as part of an annual Medicare wellness visit. So we here in the US really need to do a much better job of delivering preventative medicine than we're currently doing. And this is one important area in which I believe telehealth will play an increasingly important role as we move toward a more comprehensive, accessible, and humane system of healthcare delivery. And if delivered properly, telemedicine, I believe, can actually enhance patient relationships between doctors and patients. And if successfully integrated into our healthcare system, telemedicine may in fact become the new normal for many people, and rightly so. And newer digital technologies are emerging that will enable physicians to deliver more comprehensive, personalized, precision medicine virtually in real time. There will likely come a time, I believe, in the near future when the distinction between quality of care associated with in-person visits and with virtual visits will disintegrate, and virtual healthcare will become the new normal for healthcare delivery. And with that, I turn to my friend and patient, Mike Turpin, for a much more detailed discussion about emerging technologies and their benefits to both doctors and patients and to the greater community.
I think you should actually just drop the microphone and leave the room now.
No. This is you need to fill in all the gaps. This is your area.
Oh my goodness, that was fabulous. And from your mouth to God's ears, or at least to Health and Human Services ears. Right. So, I come to this industry from a different perspective in that I've been associated with healthcare for 37 years, primarily working with employers who spend millions of dollars on healthcare, helping them break down how they're spending their dollars, and more importantly, looking for clinical patterns and frameworks by which we can provide better health and quality outcomes for employees. Employers obviously consider employee benefits essential to what they do for employees, but now as we're aging, the lines are beginning to blur between Medicare and commercial insurance, and obviously Medicaid is available in the state for those that can't afford coverage and qualify for it. And under Obamacare, the definition of Medicaid qualification was expanded to where individuals making a certain amount of money that would normally be eligible for Medicaid would, if they were making up to 140% of the federal poverty level, would now be eligible, and generous subsidies were now available for them. Each state decided whether to expand Medicaid or not to expand Medicaid in order to capture those individuals that historically had been uninsured. And as a result, a larger percentage of individuals under the Affordable Care Act were now covered under Medicaid. And obviously the insurance exchanges were no longer discriminating against individuals that had pre-existing conditions. And many individuals could now go to the physician and or get insurance coverage. And for the first time, they actually had to find a primary care physician. And what I've experienced in the last 37 years of working across employers, I also probably omitted from my bio is the fact that for 3 years I was the CEO of Oxford Healthcare and United Healthcare in the Northeast, which was an $8 billion region. And I always joke that my diminished chances of getting into heaven were greatly increased when I decided to step away and go back into consulting. But in those 3 years, I saw what I felt were some really absurd incentives. So as Dr. Leibowitz said, the incentive is to have a system of sick care, not well care. So if Larry actually treats me, gets me to exercise properly, gets me off the statin, does all the things I'm supposed to do, he may not see me for months at a time, and therefore there's no revenue coming in from our association. Yet in parts of rural China where there are no doctors, the peasants basically pay the local physician every day that they're well, and then they stop paying the day that they become ill until they become better again. And some might say, well, rural healthcare is rather innovative. I'd say necessity is the mother of invention. And in many ways, that's the classic HMO model, where the provider is at risk to keep you well. And it creates a level of partnership and interest where it's oftentimes, it's extraordinary to me that physicians, particularly primary care, pediatrics, OBGYNs, and others get up every day and do what they do. Many graduate with enormous amount of debt. Fewer and fewer of them are going into these primary practices, which quite frankly, in the future have to be the air traffic controllers of our healthcare, because they're going to have the more holistic view of us. And as we live longer with chronic conditions, they're going to be able to have a much broader view of the entire assembly line, from well to at risk to chronically ill and stable, chronically ill and unstable, and catastrophically ill. Mm-hmm. And insurance plans and everybody focuses on what I call the chronically ill or an unstable or catastrophically ill patient. And by then, there's very little you can do to intervene with an outcome. And between the normal consolidation that's occurred with massive healthcare systems now charging larger and larger amounts, per unit of care delivered, the kind of single hang your shingle primary care physician and single practitioner is really being driven out of business because of reimbursement practices and the model that's being foisted upon them, which really compromises the basic kind of Hippocratic oath that they took, which was first do no harm, and then to basically begin to treat patients. And so we live in a suburban area, so we don't see it as much, but if you travel 100 miles north or up into New York, you're going to see entire areas where hospital closures have occurred because the hospitals are trying to live off of strictly Medicare and Medicaid reimbursements, which oftentimes are not adequate enough to cover the cost of care. Medicaid pays about 60 cents on the dollar, arguably. Medicare pays about 80 cents on the dollar, and this is of the dollar that the physician may feel they need in order to adequately run and staff their practice. And so commercial insurance is oftentimes charged about $120 to $130, and actually supports the under reimbursement that comes from Medicaid and Medicare. So there's this weird symbiotic relationship that private insurance and public insurance have, and some of it's just the dependency that public insurance has for physicians to be able to cost shift to private insurance. Unfortunately for the single practitioners, that hasn't been the case, and most primary care doctors and others are reimbursed well below levels that they need to truly provide the levels of encounter and care and quality that Dr. Leibowitz is laying out. So something fundamentally needs to change. If you have infinite demand and finite resources, you're going to get to a point where it's an unsustainable trend. And any economist would say any unsustainable trend eventually ends, and it does. Telemedicine, if you were to look in the stock market right now, you'd see a company called Teledoc, whose stock was trading at about 65 pre-COVID. It's now at 208. They basically provide an infrastructure to employers where individuals can now call and get telemedicine resources available to them. It's the first manifestation of what I call the digital economy finding its way into healthcare and creating efficiencies and ways to deliver care and quality in a manner that people really up to this point hadn't believed was possible, or they were generationally impaired, where they didn't trust technology, were concerned about privacy. My father, who is a staunch conservative and would love the fact that you called me a contributing communist. But the fact remains that he distrusts anything that is computer-based and prefers everything to be live and encounters, because if they're not trying to break into his bank account to get his money back, they're certainly going to be listening in on the call with his urologist, and who knows what bathroom wall that information will be scrawled on weeks later. But the fact remains that there is a fundamental demographic shift that's going on, and a younger generation that's much more comfortable with accessing accessing all the resources online, yet they're not consuming much of the healthcare. The majority of the healthcare is being consumed by those that are generationally on that cusp where they needed something as a tipping point event to get them to try it and use it, and COVID was that point. Because in many instances, what happened is people didn't want to go to bricks and mortar facilities because they were afraid of being infected. In many instances, individuals now are barely leaving their house. They're washing down their grocery bags. And the thought of going in for getting an eye test when you're a diabetic wasn't a big deal, but now you might actually forego some of that basic preventive care that's necessary to make sure that you're chronically ill but stable. And so my prediction is when America emerges from this kind of chrysalis or quarantine, that we're going to find that we're a little less healthy. Certainly from a mental health and standpoint, we're all going to be quite rattled. And there's going to be a boomerang effect where right now the consumption of healthcare in the US is about 20 to 30% below its normal levels. And all discretionary care, in many instances, elective surgeries, things where decisions you make as a patient or as a consumer while standing up, you're deferring or putting off initially because you had to, and now because you're not sure you want to. And as a result, individuals are going longer periods of time without getting the basic levels of care interaction that they need with their primary care provider. In other cases, primary care providers are disappearing strictly because the demographics are such that we need them more than ever now, but as a result, a smaller and smaller percentage are graduating from graduate school because they do the math, and it would take them 20 years just to pay off their debt, let alone run and build a vibrant practice. Or they're leaving and they're joining a hospital system or an HMO and just letting them provide the medical malpractice, the infrastructure, but they're no longer practicing the way they want to with the degree of autonomy, the ability to make those kind of key decisions and have the quality of life that they dreamed of when they first envisioned themselves being a provider. But the digital economy is here. Telemedicine is the first manifestation. Among the employers I work with, the initial pre-COVID consumption was about maybe 6%. And it was typically individuals under the age of 35 that were calling in, and they might have a white spot on their tonsil, and it turned out to be strep, and they're on vacation up in Lake Tahoe in California. And the telemedicine physician would look at it, they'd send pictures of it, and they would say, you need a Z-Pack, boom, you're off to the grocery store, you're not in a doctor's waiting office, you're not exposing others to your strep, and you're able to treat it and get back on vacation. The challenge you have is that that encounter paid the physician maybe $25, $30. And so from just the straight economics alone, that physician would have to be, on their telemedicine site 20 hours a day to even begin to replicate what a physical encounter could be. And then as Medicare and insurers seek ways of kind of reducing cost, it further castrates the level of reimbursement that providers are getting. So that first manifestation was a younger group. Now what we found is a secondary group that didn't want to go in and because they were nervous about getting in, and the levels of consumption of telemedicine shot up to almost 20% in a lot of firms. And the big question is, will it go back to pre-COVID levels once everyone feels safe to venture back out? But my belief is we've passed the Rubicon, and then in some ways everyone's have seen the ease and the quality and the ability to exchange information via these kinds of conversations, and have participated in Zoom calls with a variety of family members. I sadly had to preside over a Zoom memorial for my mother who passed in March, and I was very upset about it. I dreamed of 1,000 people in a church giving homage to this wonderful woman, but we had 15 of us, and it was one of the more intimate opportunities I think I felt a long time for each one of us to express ourselves, and it kind of restored my faith that we could have different kinds of encounters at different times. We need the physical proximity to each other, but when it comes to healthcare, we're getting to an inflection point where we're not taking in enough revenue in the United States to basically cover all of our obligations. We're deficit spending at close to $1 trillion a year. This year, our deficit will be enormous. At some point, we can't continue to spend, and as we ease the spending and try to reduce that, we're going to have to make tough choices about the kinds of services we provide. The US's budget right now basically has the US looking more like an insurance company with an army than it does a government. A very large percentage of our budget goes to pay for defense spending, Medicare, Medicaid, Social Security, and there's not a whole lot left after that. And with tax revenues down as a result of the economy sinking and states not bringing in the tax revenues they need to pay for their expanded Medicaid under the Affordable Care Act, we're going to quickly run into a position where there's not enough money to pay for Medicaid and Medicare, which covers close to 55% of the population in the US by virtue of those over 65 and those in need of government support. And you'll hear political debates about reducing the ranks of those by reducing the eligibility, but that just then creates uninsured, which in turn will come in, not get reimbursed for their care, but by law, providers, particularly hospitals, have to treat them until stable. And that unreimbursed care then becomes manifests itself as either a tax break or as a cost shift to commercial insurance. So there's ways in which we're just going to have to be smarter, and the patient is going to have to be willing. You're going to see, for example, New Canaan has a program where we want our residents to be able to stay at home. Imagine being able to stay at home enabled by technology that allows you to have regular interactions with your primary care physician. If you're chronically ill with what we call multiple comorbidities, which is you have several things wrong with you, all that could kill you, but if they're all kept managed, you have a fighting chance of having a good quality of life, then you're going to need to have your biometrics taken on a more frequent basis. And imagine having the information that you take put on a strip, that strip transferred to the individual. Let's say you're diabetic, that your blood sugar is transmitted, or you're transmitting your blood sugar on a regular basis. Your physician sees an anomaly. They get in touch with you and say, hey, you haven't had your hemoglobin A1C test done for a while. Your glucose is too high. Here's what we're going to do to manage that. And you've not even left your home. And I think in this era of pandemic and fear, the best opportunity is to have someone come into your home, and the Telemedicine Foundation will then lead to a very focused surge in what I call digital applications. So whether you're diabetic and you work with a firm called Livongo, who might be working with you on managing your diabetes in a much more interactive fashion, or whether you're a woman who's at a high risk for pregnancy or going through in vitro right now, and they have the ability to work with you and manage it so that you're less likely to end up in neonatal intensive care and deliver your twins or your single child prematurely. You name the condition and I could give you an application, and several companies that are trying to adopt strategies to where individuals can have telemedicine encounters and deal with physicians and specialists. And then in rural America, where hospitals are going out of business because they just can't afford to cover their cost, the emergency room has become America's primary care provider. And the emergency room is perhaps the most expensive setting. And in many cases, if those emergency room encounters don't result in admission, where 70% of them don't, which suggests that you probably could have gone to an alternative provider if you had the ability to do that. But if nobody's within a 50-mile radius that's going to be able to provide that care to you, then that's your only option. Imagine being able to deal with someone from a telemedicine standpoint, and then maybe you have a drone deliver your medicine to you. That's not the kind of stuff of science fiction. That's a very feasible and realistic picture of how healthcare could be delivered in different settings, whether they're urban, suburban, or rural. And many individuals that live in rural areas are retired military, they're over 65, they're on Medicaid, and very small percentage of them have large commercial employers that are out that are providing private insurance that can substitute for the reimbursement that those providers aren't getting. So it's a very interesting phenomena that's occurring, and digital medicine was the first litmus test, and it passed. And now the question is, what are we going to do about it? What's the adoption rate? Will the patient be willing? And can we redefine what quality of care is? And quality of care should not be, did I get to go whoever I want to go to, and did they see me when I wanted to see them? But more, did I get the right access? Was I given the right course of treatment? did they make me well quickly to get me back to where I was before, divided by what the cost of that encounter is. And what you might find is the value that's created for the patient and for the provider gives us a fighting chance to restore the quality that's been slowly sucked out of the system and really only afforded to the most exclusive subset of specialists and providers who continue to insist on higher rates of reimbursement. And antitrust has allowed health systems in New York, NYU, and Presby really dominate the market, and they can charge 2 or 3 times the going rate of a smaller hospital, yet they can't prove that their outcomes are 2 to 3 times better. They just have leverage. And as an insurer, I had to pay them what they asked because there's no way I could sell a PPO product to someone who was buying insurance if NYU and Presby wasn't in the PPO network. So knowing that the economics are such that we've allowed these massive consolidations, costs are getting out of control. Don't even get me started on pharmacy because that's a whole nother subject. But if we can improve people's rates of compliance, so they're chronically ill and stable, reduce gaps in care, give them access 24/7. Some of the worst things happen between midnight and 6 a.m. And I know Dr. Leibowitz doesn't want to get those calls, but I assure you, he's more willing to get those calls under his current arrangement. And as one of his patients, I couldn't be more pleased with the level of knowledge and understanding he has of who I am, and doesn't try to generalize my course of treatment and tries to find, wherever possible, non-medicinal ways of getting me to improve my lifestyle so that I might be able to, operate at my most optimal level of health without a pill or a medical process that might not necessarily be in my best interest, but creates a huge economic windfall for everybody that's in the food chain. So I think if we can change the incentives, the patients are willing, and we've got a new generation of providers like Dr. Leibowitz and others that are willing to set themselves up to, and we may have to pay more for primary care access, but in the end we'll pay less and we'll have significantly higher quality encounters. And I think it'll put more pressure on Medicare and Medicaid to flip the pyramid and start valuing primary care as its most sacred entry point instead of diminishing its role and putting it in a position where it becomes more of a place where one passes through or even self-refers around so they can go right to the specialist that they believe will somehow give them better counsel. And in my instance, I love the specialists I've seen in certain areas, but if you're a specialist, you have a hammer and everything starts to look like a nail. So I'll stop there, and I'm sure there's lots of questions about it, but this foundation is here. It's here to stay. COVID, one of the many, hard to see but important silver linings of it is that we're going to fundamentally change a lot of things as a result of it. And I think change is necessary, and we have an opportunity as a society and as a nation to rethink our healthcare system, or someone will, with a flick of a legislative pen, change it for us before we've really had a chance to debate and try out different models. And each state can be its own incubator, but we have to loosen up the laws. Maybe 6 months ago, Dr. Leibowitz couldn't treat a patient in another state because the law said that a physician that's licensed in Connecticut can't treat someone in Massachusetts. Well, that's silly because you do probably have the ability to access and move care around to have people provide advice if you've got some of those laws that have changed that were set up to protect providers in a particular state, but in doing so became barriers to competition and collaboration.
That was great, Mike.
Thank you.
Thank you for that. Great, and thank you for the feedback, by the way.
Question.
So, any questions for anybody? From anybody?
Don't be shy, anyone.
Larry, you might want to talk about, examples of how telemedicine has been used, how you've used it with, real-time situations, whether it's the chronically ill in each demographic group, from the younger person maybe to someone who's older, and just maybe give a real-time example of something that you think it was just a great solution that made a big difference.
Well, I can tell you that that's a good point. I can tell you that in the last few months during the pandemic, Many people have cloistered, they've stayed home, or they've left and gone to their vacation house in the country where they're really even at lower risk for exposure to COVID, but they're still running into their problems. And you know, very frequently they'll shoot me a picture, or we'll get online and do a video conference, and they'll show me a rash, or they'll, as Mike had suggested, shine the light from their iPhone into their throat so I can take a look, because it sounds like they might have a strep throat. And we can easily manage a lot of those conditions remotely, with the understanding, of course, it's not a one and done. It's, you know, we need to maintain contact to make sure that things are progressing as planned. And we need to kind of have a follow-up plan in place as a contingency if things don't work out. But that's been kind of nonstop in the last few months, you know, and I have plenty of patients, as you can imagine, with chronic conditions as well, who just really need to touch base. They don't necessarily feel the need to be seen or physically examined, but they want to make sure they're doing the right thing. They want to make sure that we shouldn't be massaging their medication regimen or some other regimen a little bit for them. And particularly for people who are older or who have some of those higher risk characteristics, people with blood pressure problems, for instance, diabetes, heart disease, who don't want to leave the house these days especially, it's been really, really helpful for them to be able to connect with me on a regular basis in order to kind of make sure that things are moving along appropriately.
And I think you have a lot of, I would think, psychosocial benefits of this. In isolation, a lot of individuals are going through enormous strain. And the ability to speak with you live, the ability to deal with the collateral benefit of just what I call putting their minds at ease, because you know, I'm probably, you know, exhibit A of the kind of high-performing neurotic male patient who looks at a bump and immediately thinks it's stage 4 metastasized.
Right.
And I need that. I don't want to run in. Certainly, my wife doesn't want me to run in. But it is a great alternative to be able to have those conversations. And
that's true. Yeah, reassurance is often the operative word. If I can take a look at something or pay attention to what people have to say, or listen to their descriptions of what's going on, it's often really easy just to provide the appropriate level of reassurance. They know that everything's going to be okay, for sure. You know, and the other thing, there was an initial hurdle, right, when people were first forced to use Zoom for everything, or FaceTime, and everyone was sort of quarantining. It took a little while to get used to this awkward sort of video interaction, but over the course of time, it's become increasingly normal in the sense that, you know, it does begin to feel like this is adequate. I'm getting what I need. I'm having the kind of communication that I need to have. I feel like I'm connecting, whether it be with a doctor, with a family member, or whatever. I think as we adapt to this sort of feeling that technology sort of lends, I think we're going to find that it's much more appropriate and acceptable. And the other thing that I've noticed is that, you know, these brief little visits, you know, remote visits, my sense is that it fosters a sense in my patients that they want to continue following up. There's a more of a desire for continuity with this kind of a modality that may not necessarily be the case if it's a hassle to go see the doctor. You know, if they have to get in the car, like I said, and sit and wait and blah blah blah. You know, it's a not a toxic process, but it's not always such a positive process for them because of all the inconveniences attached to it. Whereas this is very motivating for people. So I think it sort of feeds itself in terms of providing benefit to patients over the course of time.
Also, I think you're going to see at Walgreens and CVS, for example, health hubs now. You're going to see these traditional retailers really pivoting away from retail as a primary basis and healthcare as their primary basis. And they might even have specialists in there to deal with individuals that have diabetes. They're giving flu shots now, but you're going to see in Texas alone, they're debuting, you know, many thousands of square feet in the retailer for treating for a variety of different conditions, particularly for underserved communities where there are no providers, where they're in urban areas and there's food deserts where they can't get the right food. There are diabetic hot zones, and for the first time, we might be able to deliver accessible care, maybe partner with Lyft or Uber, and Medicare is even considering reimbursing some or all of the transportation costs to get those individuals in, and to also encourage them to use the telemedicine so that they can have more frequent encounters. And as you say, they're finding compliance rates are much higher. And those Medicare policies that a lot of seniors buy are scored by HEDIS, and the providers are health plans are graded by HEDIS and star ratings, and many of them are very low in a lot of those areas. So they're getting Ds for their ability right now as they're currently constructed, and they're desperately trying to figure out new ways in which they can get better compliance and better reach and better quality outcomes for those individuals. We're finding that you're going to see, maybe not so much in areas like New Canaan and others, but you might be pretty amazed at the next 3 to 5 years with the physical transformation of many of these retailers who believe they'll get retail traffic as caregivers wait to, pick up.
That's the question that I have. So what is their real motivation? Is it a loss leader for them in the sense that they're using the clinical delivery of care as an opportunity to get people into the stores?
I think a lot of us do. They want them to use the pharmacy because the pharmacy benefit manager makes so much money by the buying and selling of retail drugs and the rebates. And to the degree that Congress doesn't act and ever change the highly opaque and highly suspect kind of basis of how drugs are kind of set up and administered right now and charged for, everybody wants to control that pharmaceutical piece, which now is as much as 30 to 35% of many employers' healthcare spends. And drugs are only getting more expensive, and you're not going to hear anybody say they don't want to have the continued development and biotech investment in finding new cures and new solutions, particularly now during the pandemic. It's a great time to be a pharmaceutical company because no one's going to be criticizing you. But if you come out with a cure for hemophilia and it's $1 million per treatment, then you suddenly have advocacy groups coming out, and it's going to be a big debate. But they want that traffic because you're going to consume healthcare, you're going to consume pharmaceutical, and you're going to pick up a half a gallon of milk and maybe some in sundries along the way. And that may be the hub for you for many things that you do.
But I wonder how much that model might affect the type of care that's delivered, in the sense that, will they be interested in preventative health, or are they going to be more interested in those types of visits that end up with a prescription in hand, so that they can get the people into the store to the pharmacy to pick up a prescription?
It's never going to touch the highest quality, what I call the first quartile quality of health that your type of model provides. It's going to be more of a solution for what I call, those that are on Medicaid or levels of or even Medicare, where financially they're not able to, get themselves to the physician or do certain things. They're going to try to say, we're going to have a captive audience of a certain number of individuals that are already here to begin with. Costco, for example, just announced they're setting up their own health plan. So they're actually going to offer insurance to their members where they are going to be the risk taker. So you're going to see people saying, look, we have huge volumes of individuals coming through here. What can we do for them? And the issue is going to be, for some, they're not going to be as discriminating about the quality of care they're getting because they hadn't gotten any to begin with.
Right.
Those that are truly committed to their own health and well-being, understand their chronic condition and want to maintain it, they're going to seek higher levels of what I call personal care and personal engagement, because you can live longer, as we all know, but you can live longer with a very poor quality of life because you've not managed your condition. You're just sitting in a chair and someone's wiping the oatmeal off your chin. Or you can basically be out and be very active because your primary care doctor worked with you in your 60s and 70s to give you the quality of life that you need, so you're not on 15 different meds that are all having contradictions that the doctor can barely figure out, and you're not able to enjoy the time that you set aside, those golden years, because you didn't maintain the vehicle.
What I like to say, and I'm plagiarizing, but it's not just about putting years in your life, but life in your years, right?
Yes, that's the Lincoln one.
That should be the goal.
Yep.
We did have 3 questions just come in. So I'll read them in time order. One person said, what companies have been on the forefront of telehealth besides Teledoc?
There's so many that are out there now. They're all dealing, there's a company called, a lot of them are, GoodRx, for example, is one. And I should say GoodRx is more for pharmaceutical, but they're a digital solution where you may find that when you're at the pharmacy that you're able to get a medicine cheaper than your copay at your firm, at your, your covered plan is charging you, and in doing so, get a bulk discount for them on a pretty significantly lower level. So GoodRx is a great digital application. As far as telehealth goes, think of telehealth as really a piece of the digital model. And the telehealth encounter is almost going to be seen now as table stakes for most health plans. There's a company called One Medical. There's a company, there are what I call a growing number of primary care physician-based companies that are going public or that are privately financed through private equity, where they are going into large major cities, establishing single health hubs, significantly are staffed by primarily primary care providers, but some multi-specialty. And then they're basically using digital medicine or telemedicine as a key part of the health delivery, but they also have physical bricks and mortar encounters, such as Dr. Leibowitz has. But they're trying to do, they're trying to sell those services to to employers, and saying that as a special benefit, in addition to wherever people want to go, there's a whole legion of individuals at your firm that doesn't have a primary care relationship. I would say that probably anybody under 35 is still trying to get away with going to their pediatrician, but they're finally kicked out. And then they go to urgent care and they don't have a primary care provider. And you might have situations where you really need to be under a care of a primary care provider, even at a younger age, because you may not know that you have inherited cholesterol that's substantially higher. We did mandated biometrics for my firm, whether people wanted it or not. We had several people under the age of 40 that were identified with dangerous skin lesions, dangerously high cholesterol levels. They're all silent killers, didn't know it or didn't see it, but they hadn't been seen a primary care doctor in 3 or 4 years. I have a mother-in-law who's British, who's on Medicare and just doesn't like to go to the doctor, hadn't been in 4 years, and then was diagnosed with stage 3 metastasized cancer. Now, gratefully, she got through it, but it was a great example where we've got to get America going to the doctor at least once a year, and America's got to know its numbers. You got to know your HDL, your LDL, and you've got to have a conversation face-to-face with my physician where he's going to tell me, you got to do these things. And if you do that, the quality of life you have and your body will react better, and you'll save your kidneys and your liver, and you'll be in a position where you can enjoy your life. And healthcare is not a rational thing. And so it takes a lot of encounters for individuals to finally get to that point. And this technology facilitates the relationship building and the trust that's necessary to make that happen. And our current model just doesn't do that.
Yeah, I'm sorry, I didn't mean to interrupt.
One Medical, for example.
Yeah, that's one. There are a few. There are a couple of. Doximity is another one. I get a lot of ads and solicitations from there are hundreds of these companies out there, all competing for what is now a relatively small piece of the pie. That piece is going to get larger. What would really be great is if, rather than forcing practices to invest large sums of money in one of these platforms, if at the government level, they recommended the potential cost benefits of the system such that they implemented one or provided physicians at a discount or for free a really robust platform that would enable everybody to communicate with each other, rather than what we often see now, which is that these individual platforms do not communicate with each other. So I could have a colleague in the cardiology department at a hospital who uses a particular platform in his practice that doesn't communicate with my platform. And therefore it flies in the face of what we're trying to achieve here in terms of productivity and in terms of communication and continuity. It would be really nice if someday we had a unified system that really that was private and secure, of course, that enabled physicians to really communicate with each other and with patients in real time, so that we could actually collaborate effectively.
And I think we're going to see as identity-based politics and identity-based employment becomes more real for individuals, a 35-year-old couple with dual income, no kids might have different needs, women's healthcare needs, Black, Asian, Latino-based care that are based on different kind of inherited genetic conditions that might be more prevalent with them. All those things have the ability to tap in more readily and easily to a care delivery system that can deliver them better quality outcomes and better access. Right now, the traditional model is failing a lot of those communities. And in some cases, culturally, people access healthcare very differently. So once we get over the cultural and the personal barriers, we might be able to actually streamline and customize medicine to really be able to cater to a variety of underserved communities, as well as give a high quality of care. And I think we have to enable our physicians to have multiple ways to reach out to their patients so they can have those encounters, because without them, the absence of information denies my physician the ability to make good choices, to make a proper diagnosis and to work with me to get me better. And, he has to, many of us are in denial and fudging. About the third time I'll admit, the Butterfinger under my pillow, and we'll get right down to it. But it's just those things that come from that trust relationship that I have, that I didn't have before in the multiple encounters I had, which is why I chose to go to Matrix. And I think it's a very high quality solution. And I should care about my health more than anything else. And it's amazing the little amount of time we invest in it unless we have a need, because we're reacting to a symptom rather than proactively managing for a first quartile life experience.
Mm-hmm. Well said, Mike.
Thank you. Our next question is, how are seniors who might be less technically oriented to adopting telemedicine? So any advice on how I can help my senior parents who don't live near me use telemedicine?
Well,
in terms of like the technology and whatnot.
That's a really good question, and it is a barrier for a lot of people who did not grow up in this this virtual age. I can give you very recently, in fact, last week, I had an experience with a patient that I found I just had an epiphany, in the sense that this is a woman who lives alone. She's very isolated. She's not able to get out of the house that easily, a number of medical conditions, and she's not at all technologically oriented. She doesn't really, she has a cell phone, but she doesn't use it. She has a television. She doesn't really get involved with any internet activities whatsoever. She finds it very daunting and intimidating. But we had a frank discussion. I said to her, you're really isolated, and we can't communicate as effectively as a result, and you're missing your friends. She doesn't want to go to the library to pick up a book because she's concerned about leaving the house. And I said, you can read a book on a device virtually, but it takes some learning. And I reached out to the town, actually. I spoke to Bethany Zarro, who's wonderful. Whoever doesn't know her, get to know her. She's great and a wonderful resource. But she was able to connect my patient to someone who came to her home and got her set up with an iPad and taught her how to use just a basic instructional session, which enables her now to be able to FaceTime with friends and family, which she was never able to do before. She can download a book and read it. She can have access to news and other information that she didn't formerly have access to, and she can communicate with me. This was just last week. So I think if we can reinforce the need for communities to be able to educate those segments of the population who aren't otherwise able to easily access technology, that can go a long way.
I think just going to the Geek Squad and paying them $60 an hour to come to your house and right. Teach you how to use that iPad and maybe help you get a stronger router so that wherever you are within your home, you're able to get a strong signal. Right. Mm-hmm. And then basically, I'm so impressed with the quality of those individuals that come through, and they come in, they've got gloves, they've got their masks on, and they're able to come in and walk these individuals through. So you live far away, you call the local Best Buy, you get in touch with the Geek Squad, you buy an iPad, you use the purchase of an iPad as the means to have it delivered. Then you ask for an hour's worth of the Geek Squad's time, and you give them specific instructions about setting up Zoom calls. And to the degree that the physician that the parent has is able to give them a telemedicine experience, great. And if they don't, then the greatest you can give to your parent would then be to help them purchase access to, if they need to, see a primary care provider privately that might be in one of these practices right now, because not all of the many of the primary care practices just are not embracing telemedicine because their economic models built around patient encounters, and they won't talk to you on the phone about anything unless you come in.
Right.
And to Larry's point, the incentives are perverse to where they're much more likely to give you a prescription and send you home because the CPT code that's circled for that encounter pays them more than the CPT code for a conversation about personal health management.
Right.
So part of it is the health system itself that is the barrier to that senior, because you could get them as technically astute as you want, but if there's nobody that's willing to be on the other end of the call, because in that area, those providers just are not organizing in a way, because they at some level feel like they're cannibalizing themselves by agreeing to these lower paying encounters, which are just going to create in their mind higher volume of patients with lower levels of reimbursement, because they're still practicing in a traditional way versus having the courage to break out and try to establish a more concierge approach that, quite frankly, is existing in every single country I ever worked, will always be there. And many individuals have public health care, and then on top of it, they purchase private solutions anchored by a primary care relationship. And sometimes that primary care relationship is with a provider that treats them both publicly and privately in certain countries.
Interesting. The other point about people who are not technologically savvy being sort of isolated at home is that, particularly these days, we're dealing with a lot of emotional strife and loneliness and stress and angst. And that's going to take a toll. You know, we're going to see a lot of mental illness when this thing is all over. Probably some increased addiction we're going to have to be dealing with. But the telehealth works really well for people who need to touch base with, for instance, a therapist or a life coach, or someone who can help talk them off the ledge and help them manage their anxiety and their loneliness in these strange days. Most therapists and psychiatrists, psychologists who I know these days are doing telehealth. You know, they're not seeing clients in the office. I know a couple who will sit outside with a client and do a session, but pretty much everybody's doing telehealth these days for mental health purposes. And I think that's a missing piece that's critical, particularly these days. And this technology will enable people who are otherwise homebound or lonely or isolated to be able to access those services as well.
I just have to teach my father to stop putting the phone up his nostril. I can see his right sinus very well, but that's about it.
And I'll just plug the library too and say that our digital services department, we've been working pretty closely with LAPM, with Staying Put, with Bethany Zaro to provide seniors and anyone in New Canaan with technology help if they need it. So we're all kind of working in alliance together, and anyone who's on this call right now or who knows someone who needs technology help, the library is also a resource.
I would also argue that a town like ours is typically anchored by its educational system, but also by its providers and the quality of care. And imagine that we have a wired community where you move here and you can stay here, and we've got an infrastructure built that really accommodates individuals. So when they move in, they don't have to move out. And it's only the most, so imagine, every care facility has ambulatory, and then as you progress in age and become more dependent, you kind of move through different parts of that facility. But I think COVID got people very frightened to the notion of kind of, to traditional residential care, have the ability to wire a community and have an infrastructure that's really committed to that. The vitality, economic vitality that the town would enjoy and the stickiness to its residents would be extraordinary. And it would really contribute a lot economically to this region if we just were smarter about it.
And if we had a platform that enabled doctors and patients to communicate, but also could loop in other family members, to have a group meeting about a particular health matter, all the better. So there's so many opportunities. If someone has a daughter who lives across the country, but has a lot to say about what may be going on with her mother or father or grandparent, it makes the whole healthcare experience much more effective, and enables a much better quality of care in the long run. And this can only be achieved with telehealth. So, there's so many good reasons why we need to kind of really jump on this.
I think it's incredibly exciting, but it's going to require everybody to be open to it and quit getting paranoid that the Russians are listening in on the conversation. Right.
So here's a last question for you both. Someone says, thank you both. I have my first telehealth with my PCP tomorrow. and now I feel less anxious. I'm not sure why the Yale MyChart virtual visits are only accessible by phone and not computer. Do you think that's a security concern? Dr. L, can your patients use phone or computer?
Well, I can't speak for what the Yale Health team is doing. I feel like it is there are many cases in which a conversation is sufficient, right? But if you really need to be face-to-face with somebody, you want to take a look at somebody just to get a general gestalt, a sense as to how they're looking, how they're feeling, or if you want to take a look at a specific aspect of their body, you can't substitute the video component. So I'm not quite sure why they would eliminate that. It may be a cost factor. There may be some security matters that they're concerned about. Maybe they're scaling up slowly. I don't know, but I can tell you that in my practice, I do this with my patients. I have telephone conversations with my patients, whatever may be relevant. Last week, I had a patient who's not in town. It's a family, and this is a girl who's going to be heading off to college, and she needs a physical to be able to go to college, right? But she's in Massachusetts, and she doesn't want to come home for a physical, nor does she want to leave and travel because of all the risks, which we don't need to talk more about. But I was able to do a virtual physical for her. Now, could I check her blood pressure? Could I actually listen to her heart and lungs? Of course not. I can't do that. Although, if time permits, Mike could probably talk about some of the technologies that are going to be enabling us to do that kind of thing. But at the very least, I know her history. I can take a detailed history, as I said before, ask all the right questions, listen to what she has to say, to discern that a reasonable assumption is that her heart and lungs are fine. I can watch her breathing. I can ask her to check her pulse for me. I can ask her to move her eyes from left to right and up and down. I can look at the skin. I can look at joints. I can watch them move their extremities to make sure there are no muscular deficits or neurologic deficits. So I was able to execute a physical virtually to the extent that it enabled her to be able to provide the proper documentation, so there were no gaps in her care, and that she was able to get into college without any difficulties, assuming, fingers crossed, that her college opens. So, so that would be a most recent example of how the virtual video aspect really came into play.
I think that some of those can be too, that sometimes the phone interview is a level of triage. Mm-hmm. Individual is talking to someone and wanting to get a sense of whether or not it's worth the physician's time to get on the phone and go deeper on it, or whether the nurse practitioner or the attending physician's assistant can field or deal with some of those issues, because like everything else, you're going to take in a bunch of information, give it to the provider. I look at all this and I'd say your health is an investment, it's not a cost. Mm. And so to the degree that you look at this as an investment, and if this is the only vehicle you're going to drive, hopefully until whatever age you feel you've had enough, you want to basically be making that annual investment every year. And this is to me, the investment in this level of care with this level of quality and caring is going to be absent in big chunks of the market where the model just does not incent that kind of behavior. And so younger people coming out might just say, you know what, I don't need to hang my own shingle. I'm going to go work for Kaiser. I'm going to go work for that. And Kaiser has its own incentives as a staff model HMO whose focus is, look, I'm going to try to keep you healthy. And they're going to call you and get after you if you don't come in for your sigmoidoscopy, because they know you're at high risk for colon cancer. And if you don't come in because you're a male and you're chicken, they're going to stay after you because they bear the cost to the degree that you come down with colorectal cancer because you weren't attentive to your own health. So imagine how shocked you would be as if you got a call from your primary care provider as it's currently standing now saying, hey, I haven't seen you for a while. Is everything okay? How's your HDL and LDL? Let's come in and deal with it. Or let's maybe find some way where we can just talk about, or how are you doing through the pandemic? I mean, that level of trust, some people don't get that from their own children. So I would just say that this is the kind of model that many people who have the means will migrate towards, and it will become a very vibrant part of our society, but it will be based on the kind of socioeconomic kind of distribution of where people are. It's not going to be everywhere, but telemedicine will be everywhere because in many ways it will be the only option to provide the level of care we need to take care of those underserved communities and start to solve for some of these problems that we're watching on television, when disproportionate amounts of certain communities are dying from conditions, dying in childbirth, dying in from disease, because not so much because they're underserved, but maybe they are diabetic and have other comorbidities. And as we know, the more things you suffer from, the higher probability you are to succumb to some of these diseases, including COVID. So, it's just a natural growth, but it's something that should not be feared. We should teach everyone how to use it. And I guarantee you, once you use it enough, nothing replaces that intimate personal encounter. But I challenge everybody to say, when's the last time you came away from a normal primary care visit at a high volume, location where you said, wow, that was a really great encounter? No, I'd wait, and I saw the nurse practitioner for 70% of the time, and the doctor came in and did a drive-by and prescribed something, and boom, away I go. And that's very, very different than someone who's basically trying to find a way to manage your condition in such a way that you yourself are empowered to stay healthy at the highest quality possible. Very different.
It's been my experience for sure.
So we do have one more question. I don't want to run too over time and take up your time. Can we take one more question? Is that okay?
Yeah.
Okay. So this is the final question, and then the audience is wondering if you can post your both of your contact information in the chat if you're comfortable sharing an email or phone number. But the final question is, how much does it cost for a patient to be in a boutique practice in general? Does private insurance pay any of it?
Well, that's a good question, and there's great variability. Some practices charge. There are different models. It can be as low as $500 a year, but they're billing insurance, and it's a higher volume version of a concierge practice. More typically, the average is $3,000 or $4,000 a year, but you can find a practice in some areas around Fairfield County, certainly New York City, where the cost is $10,000, $20,000, $30,000, $40,000 a year. And that physician maybe takes care of 50 patients, right? Has a very, very small panel, and he will get on a plane to meet somebody on the 9th hole if suddenly they stub their toe and they want someone to take a quick look, and everything in between. So, it does require some shopping around, but I would say in our neck of the woods, the average range is $3,000 or $4,000 a year. Some practices offer family packages or discounts for couples, that sort of a thing. Some practices charge insurance in addition to their annual membership fees. Some do not. I do not. I sort of feel it's kind of double dipping. I made that decision, and it eliminates a lot of administrative headaches for me to not have to be bothered with that, which means I can spend more time with my patients. So that was my decision. Insurance generally will not cover a membership to a concierge practice as a discrete medical expense. It's usually out of pocket, although I have a lot of patients who have HSA plans attached to their insurance policies, and they use those HSA dollars to cover the cost of an annual membership. And I have not once had a patient tell me that they had any kind of bounce back as a result of that. So that's one way that those pre-tax dollars can be used as a means of covering and making up the difference a little bit. But in general, insurance will not pay for practice membership fees.
Yeah, and I would say the gross cost would be, on average, let's say $3,500 or $4,000 for a high quality provider that's committed to it. They also have a finite amount of availability because it's very popular. You're going to find that the best ones are going to be almost full. And I would say the best ones, it's hard to say because once they adopt the whole kind of continuum of care, I would argue that they're all going to be following similar examples. And then it's just going to be, do I really click with that individual? Do I feel that they understand me and that if I call them, they're not going to make me feel like a neurotic, person but they're going to really be empathetic and also have a way of getting me to do the things I need to do to participate in my own health maintenance. But you're going to be defraying other costs so that you might have incurred that are going to be coming down the road from chronic illness, from loss of time, from the inability to, participate in things in life that a first quartile health is a target with. I consider Larry my coach as well as my provider, and that, I told him what my goals are, and we're getting towards those goals for weight, for, all the things that are necessary after years of just kind of being given a prescription and someone genuflects, and I might see them for their six months to 12 months. So, but I'd say generally insurance won't cover it. As you know, Medicare is not going to cover those things. You're going to end up but in Medicare, you're going to get lost self-referring yourself to specialists. Medicare, because they reimburse less, I'd argue that they're going to make up in volume what you lose in kind of the individual. And I believe a lot of us are overtreated. I believe that a third of healthcare in the United States is avoidable or unnecessary because individuals are compensating for what they're not getting in unit cost by providing services or defensive medicine where they're running tests and all kinds of additional things. And we're so trusting and deify our partners and providers to a point to where we trust everything we say. And if someone says, is that necessary? We look at them like they've questioned our loyalty, to the flag, because, God forbid that my provider would ever suggest something that isn't necessary for me. But we've all, at least a third of all diagnoses, when given a second opinion, would have a potential different course of action. And so to have a PCP who's your partner and wingman when you're getting specialty care and doing other things and seeing you in the hospital or whatever, it's priceless. So I realize everybody's not in the economic bracket and seniors live on a fixed income, and that's seems like an indulgence. But when you break it down into, $300 a month, and then you think about the other things that you could be, learn how to stream your cable and get rid of your cable, and that'll get you about 150 of that 300 right there. I mean, there's just all kinds of things that you can do, and what's not more important than your health.
Sure, and you mentioned defensive medicine. That's very costly, right? Basically, what that means is doctors are ordering excessive tests, spending a lot of extra healthcare dollars that they don't necessarily feel inside that they need to spend, but for the fact that they want to make sure they've covered all their bases and their defense is set up in the event that something doesn't go well. I find that in this model, I'm not practicing defensive medicine nearly as much. I'm dotting all I's and crossing all T's, but I'm not as worried. I have a real relationship. It's a real partnership with my patients. So I don't have those concerns that I need to have them spend more of their precious healthcare dollars on tests that I deep down really don't believe they need. There's a trust, it's a relationship, it's a partnership, it's a collaboration, and there's a significant opportunity for cost savings there as a result. So thank you for mentioning the whole defensive medicine piece. I think it's really important these days especially.
Well, thank you both so much.
Okay.
I have so much to think about. I'm hoping everyone else feels the same way.